Welcome to Texas Heart Institute educational programs on innovative technologies and techniques. The purpose of these presentations is to inform and educate physicians and allied medical personnel as well as the general public on the latest advances in endovascular medicine. The topic of today's presentation is on the latest advances in endovascular treatment of ascending thoracic aortic aneurysms. I'm your host. My name is Zvonimir Krajcer. I'm an interventional cardiologist at Texas Heart Institute and Baylor College of Medicine. And I'm also a professor at Baylor College of Medicine, as well as the president of the International Society of Endovascular Specialists. Our special guest today is Dr. Ourania Preventza. She's a cardiothoracic surgeon and professor of surgery at Baylor College of Medicine and in the Department of Cardiothoracic Surgery at Texas Heart Institute and Baylor CHI Medical Center. She's also president-elect of the International Society of Endovascular Specialists. Dr. Preventza, can you tell us a little bit about your personal experience related to the endovascular treatment of ascending thoracic aortic aneurysms?
Dr. Krajcer, thank you for the invitation. It's really a great honor to participate in the educational programs that Texas Heart Institute has in place. These are really very exciting times, especially with this technology that is on the horizon.
Very good. Dr. Preventza, can you tell us a little bit about your personal experience related to the endovascular treatment of ascending thoracic aortic aneurysms?
Thank you for this question. So we actually, just to make sure that the audience knows that currently there's no really FDA-approved device for endovascular repair of the ascending aorta. So when we look back our experience, that was published at the Annals of Thoracic Surgery in 2014. We look and we had 7 patients, consecutive patients, very high risk with different pathologies in the ascending aorta. And we'll use whatever was available on the market, but not specifically for pathologies of the ascending aorta. So the pathologies were pseudoaneurysms, iatrogenic correctation, and so forth. And the median follow-up was 14.4 months. We had 1 open conversion during our study, and we had 1 death in a patient at 30 days. But we didn't have any aorta-related death. For example, this is one of our patients. This young patient had multiple surgeries at the past, and he had this pseudoaneurysm in the proximal suture line. At the time, we really thought that having these 3-4 prior sternotomies was a high risk to intervene. So we thought that maybe it's better to proceed with endovascular repair. So what we used at the time was the gore excluder, 2 abdominal cuffs, 3.3 centimeters in length, each one of them. And also we used the anominate express stent to be placed in the anominate hemotic artery. And this patient at the time actually did very well with exclusion of his pseudoaneurysm. This is another example of another patient, 59-year-old, who was transferred to us. This patient had a prior type 1 aortic dissection and proximal arch repair. Also, he had prior coronary artery bypass. Now, prior to transfer, the patient found to have a small frontal intraparenchymal bleed. In this patient, initially, we used an Amplatz cribiform device, occluder. And after the use actually worked pretty well in the beginning, but then when we did a CT scan, we still saw some endoleak. So at that point, we decided to explore other options. We did do a coronary angiogram, which showed that the vein grafts were excluded. So after making appropriate measurements, we placed a Gorta graft 3410 in the ascending aorta, and the CT scan showed no residual endoleak. This is something that we recently presented at during the TIVAR Symposium of the Society of Thoracic Surgeons in April 2019 on a patient with a chronic type 2 aortic dissection. We're very lucky to be here, as I'm going to discuss later on. We're part of the ARISE trial, so we use this investigational device to treat the ascending aorta endovascularly. So here we see that the proximal and the distal landing zone were approximately 39 millimeters. So we use this device. This is the Gore ascending stent graft that we use for this particular patient. And the initial device was 40 by 10. And as we see on the left-hand side, the device is partially deployed by 50%. At this stage, we're able to move the device proximally and distally. And also there is a proximal angulation control that can actually conform better into the inner curvature of the ascending aorta. And then, after we are happy, the device is deployed, as you can see here on the the device was deployed, and then we can still control the angulation proximally. In this particular patient, after the 40 by 10 device was deployed, we still have some endoleak, so we deployed the second device, the 45 by 45 by 10, and you can see the last imaging that we didn't have any remaining endoleak. And this is the post-op imaging of this patient. So this is really very exciting, a very exciting technology, and we're very happy to be part of this.
Dr. Preventza, thank you very much on this very interesting information that you just shared with us on the endovascular treatment of ascending thoracic aortic aneurysms.
Thank you, Dr. Krajcer. So what is your experience with the endovascular repair of the ascending aorta? I mean, you have tremendous experience with all the wire and catheters techniques. So what do you think about this technology and how you have used it?
Well, I would like to share with you and individuals that are interested in learning more about the endovascular treatment of ascending thoracic aortic aneurysm on the least invasive techniques for endovascular repair of variety of pathologies in the ascending aorta. Now, there are numerous common challenges with endovascular treatment of ascending thoracic aortic aneurysms, and you mentioned some of them already. Number one is anatomical complexities, particularly related to the proximity of the coronary arteries to the origin of the aneurysm, as well as the proximity of the aortic valve, and also issues with the inner curvature, as well as the origin of the innominate artery. There are also hemodynamic forces that play a significant role as far as accurate deployment of the stent grafts and respiratory motion that occurs and can affect motion of the stent graft during the deployment. Now, there are also device issues that are related to this particular pathology, and one of the very important one is that the devices that are currently available, that are currently on the market, are large in profile as far as the delivery system is concerned. They're typically 22 or 24 French in profile, which precludes the use of these devices in some individuals that have relatively small access vessels, particularly femoral arteries. Also, as far as the nose cone of delivery system is concerned, it is not designed for this purpose, and it typically is very long, and therefore very frequently we would have to advance the nose cone to the left ventricle to be able to deploy the stent graft in accurate position. The purpose of this presentation is to share with you the least invasive technique in endovascular repair of ascending thoracic aortic aneurysm that we have been using at our institution for the last several years. I would like to share with you our experience with the first patient that had this approach, and here is his clinical presentation. This was a 79-year-old male that was referred to us for endovascular repair of his saccular ascending thoracic aortic aneurysm. This problem was discovered after the patient suffered a cardiac arrest, which was complicated by ventricular fibrillation, cardioversion, and subsequently the patient underwent ICD placement elsewhere. This patient had multiple comorbid conditions, which included chronic heart failure, previous history of surgery for mitral valve repair, extensive problems with congestive heart failure, with low ejection fraction, and his echocardiogram at our institution revealed evidence of a mild AI and severely depressed left ventricular ejection fraction of 28%. When we had an opportunity to review his CAT scan of the thoracic aorta that was performed elsewhere, we were able to see that his aneurysm measured 6.3 centimeters in diameter, and it was located on a greater curvature of the ascending thoracic aorta. Fortunately enough, the aneurysm originated several centimeters above the origin of the coronary arteries, and also it was several centimeters from the origin of the innominate artery. On the right side, you could see an angiographic image showing the origin and the size of this saccular ascending thoracic aortic aneurysm. Now, due to this patient's high surgical risk, endovascular ascending thoracic aortic aneurysm repair was performed using local anesthesia, conscious sedation, percutaneous femoral artery approach, and right ventricular pacing. The percutaneous approach to the right and left common femoral artery was performed using ultrasound guidance and micropuncture kit to obtain the most appropriate access to the common femoral artery. We used the pre-close technique with a ProGlide for pre-close of the left common femoral artery and left common femoral vein, and we also used the pre-close technique with ProStar for the access of the right common femoral artery. After the pre-close technique was completed in the right common femoral artery using ProStar, we placed in the common femoral artery 22 French sheath that was used for advancing the thoracic stent graft for endovascular treatment of the thoracic aortic aneurysm. 6 French sheath was placed in the left common femoral vein for right ventricular pacing during the endograft deployment. Now, the aortic valve was crossed with a standard approach that we used during TAVR. In this particular scenario, with 5 French JR4 catheter and straight wire. And then once we entered the left ventricle, we were able to exchange this straight wire with a super stiff 0.035 Lundquist wire, which was positioned in the left ventricular cavity with a technique that is commonly used during TAVR. At that point of time, we were able to advance the Valiant stent graft that measured 44 millimeters in diameter and 80 millimeters in length over super stiff Lundquist wire to the desired position into the ascending thoracic aorta. At that point of time, we initiated right ventricular pacing at the rate of 180 beats per minute, and as we can see on the image, the blood pressure was lowered down to about 50 millimeters of mercury to make sure that there was no movement of the stent graft during the deployment, and that offered us a very accurate, reliable deployment of the stent graft in the ascending aorta. And on the right-hand side, we can see the final angiogram, completion angiogram after deployment of the stent graft, revealing satisfactory results, patent right and left coronary artery, no evidence of aortic insufficiency, no evidence of endoleak, and also patent the innominate artery, revealing satisfactory results. This patient's postoperative course was unremarkable, and he was discharged the following day. I would like to share with you a clinical presentation on our second patient. This 54-year-old male had a previous surgical repair of ascending thoracic aortic aneurysm. As a matter of fact, this procedure was performed 5 days prior to this intervention, and during his postoperative course, he developed sudden precordial chest pain while coughing. His physical examination at that time revealed a low blood pressure of 80/60 millimeters of mercury. His emergent EKG did not show any abnormalities. We decided to perform an emergent CT scan, which revealed presence of a large pseudoaneurysm, which originated actually at the origin of the sutures, similarly like what Dr. Preventza presented in her information on one of her patients. And this patient, due to his comorbid conditions and due to a recent surgery, was reluctant to undergo surgical repair of this pseudoaneurysm and desired to undergo endovascular repair of this pseudoaneurysm with a stent graft. So again, we used a similar technique as described in the first patient, using a local anesthesia, conscious sedation, percutaneous approach with ProGlide and ProStar, and right ventricular pacing like in the previous patient. We were able to advance the wire to the left ventricle and then exchange it for a super stiff Lundquist wire. And in this particular scenario, we used a different stent graft. We used a commercially available Cook TBE, 32 millimeters in diameter and 80 centimeters in length stent graft, which was again deployed during RV pacing in desired location without any endoleak. What we can see here on the left-hand side, that the nose cone of this particular device is significantly longer than on the previous stent graft, and actually this nose cone protruded all the way to the left ventricle and almost to the end of the Lundquist wire. The final result that we can see on the right-hand side showed satisfactory results and the patency of the coronary arteries and also of the innominate artery, and no evidence of aortic insufficiency and no evidence of endoleak. This patient had an unremarkable postoperative course, and he was also discharged the following day. And we here can see CT images of the CT study that was performed 1 month after his intervention with satisfactory results, with no evidence of endoleak and gradual shrinking of his pseudoaneurysm. This patient continued to be asymptomatic with his aneurysmal disease. Here is the last patient, that was also very complicated. He had a previous history of aortocoronary bypass and developed several years after his surgery pseudoaneurysm that originated at the anastomotic site of the vein graft from the aorta to the right coronary artery. This enormous pseudoaneurysm was causing a lot of pain and discomfort, and the patient was referred to us for endovascular treatment. Similarly, like in previous cases, we performed the procedure with local anesthesia, percutaneous approach, and right ventricular pacing. And again, we used here Cook TBE stent graft to exclude this aneurysm. His follow-up images revealed, again, satisfactory results and no evidence of endoleak and no evidence of aortic insufficiency and patent coronary arteries. And this information we published relatively recently in the Texas Heart Institute journal. So, in conclusion, from our experience, endovascular treatment of ascending thoracic aortic aneurysm is associated with multiple challenges with current generation devices, as Dr. Preventza has mentioned previously, particularly due to a smaller number of patients that are ideal candidates for this type of repair due to lack of adequate technology at the present time. Local anesthesia and percutaneous approach that was used in our patients greatly benefits patients with serious comorbid conditions that would otherwise not be good candidates for surgical repair. I think that further refinements in technology and technique are needed to offer this modality of treatment to a great majority of patients with this condition. But in our opinion, our experience and technique that we have described with the percutaneous approach, local anesthesia, and RV pacing is something that can be used in a great majority of patients with this condition and lowers the risk and lowers the morbidity and mortality with this type of a condition. Now, I would like to ask Dr. Preventza, of course, you briefly mentioned there are some improvements and there are some innovations and there are some research studies that are ongoing related to ascending thoracic aortic aneurysmal disease and improvements as far as the technologies and techniques are concerned. One particular one is a RISE-GORE trial that's ongoing, and you are part of it at our institution. Can you briefly mention what are the inclusion-exclusion criteria with this particular technology at the present time, and what you think, how many patients from your population of patients are candidates for this type of treatment at the present time, and also what the future might hold?
This is a great question. So we're actually very fortunate and very honored to be part of the ARISE trial. This is a GORE Type A dissection early feasibility study, which actually is the first industry-sponsored FDA-approved trial, which evaluates the endovascular repair of the ascending aorta, and the focus is to assess the feasibility of the repair. The ARISE trial actually includes the device is very interesting. The way that it works is actually conformable, exactly, and initially deploys at 50%. At that time, still, because of the controlled deployment, as well as for the, this unique feature to have a proximal control that can, a proximal deployment that can be adjusted, it can be adjusted to conform the inner part of the ascending aorta, of the curvature of the ascending aorta, can still actually adjustment can be made. So after somebody is really very happy with the placement, proximal and distal landing zone, then the device can be fully deployed. The good thing is that still at that point, even if it is fully deployed, adjustments can be made so the inner part of the graft with the inner part of the ascending aorta can be in full agreement, in a way, you can say. As you can very well mention is that a lot of times the nose cone, as well as the wire, of course, it's really the advisable is it needs to be inside the left ventricular cavity. So one of the exclusion criteria for this patient is patients that they have mechanical aortic valves. Because of course, you know, when the nose cone goes through the aortic valve, then the patient gets acute aortic insufficiency and decompensates. So this is, I think, something that overall, as we're moving forward, I know that multiple companies as well as technology needs to be improved, but definitely this is one of the exclusion criteria for the patients. The inclusion criteria is all the patients that they have acute type 1 and type 2 DeBakey aortic dissection. With regards to the aortic valve, if somebody has a bioprosthetic valve, that's a kind of a little gray area, and definitely discussions with the patient and the company usually are needed. But it's also, we really need to be able to see and define the tear and where exactly the tear is located with regards to coronary arteries, and also the distance from the coronary arteries, because we need to have at least 2 centimeters. So as you can realize, most of these patients, they come in the middle of the night, some of them, they're hemodynamic and stable. Placement in the trial means that the patient is stable enough to undergo a specific, study, a CT, also to be able to wait for the device. But we're very, very excited to use it. I think it's a great technology with a lot of potential.
Mm-hmm. So it's not for all comers at the present
Absolutely,
time.
yeah, it's not for all comers.
But it definitely is an improvement in comparison with previous generation stent grafts.
Yeah, absolutely.
Excellent. This is very, very exciting. And I think the future is bright as far as ascending thoracic aortic aneurysm is concerned. We just have to be a little bit more patient and hope that there will be further improvements and refinements as far as this particular issue is concerned. So once again, thank you very much for the opportunity to share with us your experiences and the latest advances in endovascular treatment of ascending thoracic aortic aneurysm.
Yeah.
Thank you very much.
Thank you, Dr. Krajcer, and really I would like to congratulate Texas Heart Institute for putting these educational programs into place. Are extremely important, and for all these technologies that has to do with innovation and whatever new comes into the horizon.
Thank you again for joining us at this educational program of Texas Heart Institute. We certainly hope that you will be able to join us in the future for similar programs.